Welcome to Empowering Plans, a show dedicated to identifying waste and undue expense in the health benefits industry, discovering ways to maximize benefits while minimizing costs, and empowering employers, administrators, and consultants to emphasize, once again, the benefit in benefit plan. Today's episode is brought to you by the FIA Group, empowering plans since 1999. Now here are your hosts, the FIA Group's own CEO, Adam Russo, and Senior Vice President and General Counsel, Ron Peck.
And Brady.
Hello, everybody, and welcome to another episode of Empowering Plans with the FIA Group. My name is Adam Russo. I am your co-host today on a wonderful day here in Boston. With me, as always, is my dear friend, my co-host, Ron E. Peck. Say hello, Ron.
Hello, Ron.
And because people came back and said, we need more Brady. Actually, it was just one person.
I was going to say, who are
It
those
was a
people?
postcard I got.
Yeah.
It was from Brady's mom, but she sent it. So we said, you know what? Let's bring Brady back today. Everyone, say hello to Brady.
Hi,
Hello.
Brady.
Hello, Brady.
Hey.
And as always, our dear, dear producer, Pat Santos. Wave to everybody, Pat.
That was not
He's
a wave.
not waving. He's not. You know, we should just give Pat a microphone.
Honestly.
Has anyone ever heard Pat's voice?
No.
I have once.
Pat's been here 15 years. Have we done a Face of Fear with Pat?
You know, it'll have to be one of the vlogs with the video because there's not going to be much audio
He's like
content.
that guy from Home Improvement who you never saw behind the fence.
Oh, yeah,
That's
yeah.
him.
Those of you who think that Pat Santos should be the next Face of Fear, please let us know. I think we might have to do it. I mean, we could always get someone just to speak for Pat and pretend to be Pat.
You know what, Adam? Pat speaks through action. His actions speak louder than words.
I guess so. Folks, I'm getting really old. I've realized that my birthday's coming up, and I've got a lot in my life. But, man, I mean, I'm definitely better looking now than I was 10 years ago. Better shape. But the age is still the age. I mean, every day that goes by, it's a little scary. I'm 45. That's old. I mean, if I was 20, a 45-year-old person is like, they might as well be dead.
You know, you're making me feel mortal right now. This is kind of a downer.
I know. Anyways, I figured I'd let these guys go first. I mean, that's not typical. You know that. But Brady's been dying to talk about some big issues that are on top of his brain. Today's more like a free-for-all. We really like to, every once in a while, just all three of us come up here and we just rant. We just rant about what's bothering us, what's going on in the industry, and just things that we just think need to be said. So, Brady, let's turn it over to you, bud.
Sure. Thanks, Adam. So, yeah, I mean, part of the reason why there's so much to talk about, right? There's so much going on, both in D.C., politically, legislatively, in regulations. But what caught my eye this past week, actually, was an explainer article that was published by Vox Media. They do a really good job covering healthcare. And what I've noticed in the last year even is that a lot of the articles that they publish, it's almost like they're behind the eight ball because they're all issues that we've seen in our industry and that we're taking action to try and address. And one of those issues, they have an explainer on how to fight an outrageous medical bill. It's like 7 steps they have. And as I was going through this article, reading it, I'm thinking, we do all these things. But I caught some buzzwords in their article that I thought were interesting, that it indicates to me that they're starting to make it through in the national media. And those buzzwords are patient advocacy is one of them. But let me just give you a quick example of some of the bills that they've been investigating, these ER bills as examples. So here, a woman in California fell off her bike and now faces a $20,000 bill. A patient in New Jersey never even made it past the ER waiting room and ends up with a $5,700 bill. A dad in Connecticut got a bill for $600 for a Band-Aid on his 1-year-old's daughter's finger. So those are the 3 stories that they start with. And they say, obviously, patients can't afford these bills. What do they do about it? And they have some suggestions here, like challenge what's in your bill and how it was coded, which we know.
Which we've been incentivizing our people to do for a long time.
Absolutely. Look for duplicate claims. Look for things that they bill for that didn't even happen. Happens a lot. Ask for a prompt.
The funny thing about that, when you bring that up, most employers in their self-funded plans do nothing to incentivize any of their employees to do any of these things.
Right.
So this article is talking about, these large bills that the patient's facing. But overall, most of these bills are being paid by the plan, giving the patient no reason to actually look at them, which could really lower the cost. I mean, what we've done is we have a 20% savings share that we give to the employees if they actually find something on their bill that's wrong. That's huge. And the fact that very few self-funded plans do this, when it costs them nothing, they're actually going to save money every single time. To get your patients to become consumers of care is something that people just don't do.
Yeah, and one of the bills that's most likely to have errors in it is an ER bill. They give an example here of something that I've known about. It's called a facility fee that the ER will charge you even if you don't get seen. It's like you're leasing the space in case you're needed. And there's this facility fee that ranges from level 1 to level 5. In one case they referenced here, a guy was charged $11,000 level 5 fee when he went in for a migraine. And so when he went to the ER and said, hey, what's going on with this bill? They actually reduced it to a level 1 fee, which is $500. So Who knew that that could happen? But going through this list here, ask for prompt pay discount. We've been doing that for years. Call them, call again and again. These are things that seem obvious, but apparently I think they needed to explain it to everyone here.
So, Ron, I know you're tying an article you're writing now for the Self-Insured magazine that's tied into Saya, and it talks about some of this stuff, right?
That's right, Adam. Actually, it's interesting that you're talking about this right now, and we didn't plan this at all, but I've been beating the drum a little bit on transparency, and I recently posted a blog post on our website, and I'm building out onto that now with this article, and it ties very closely into two of the things that you guys were just talking about. Brady, on your point, the fact that these bills come in, and they're extraordinarily excessive, people are shocked, and now they're asking, well, what do I do sort of after the fact? And there's this attitude out there that, well, had I known what it would cost, I would not have gone there in the first place. And yet, some of these situations, you're talking about emergencies, other situations, I think people do know more often than not that people think, there's no transparency in healthcare whatsoever. But you could hop on the internet right now and do a search and say average cost of an appendectomy. You may not get the specific cost at one facility versus another, but you have a general sense for what it costs. And I think this ties into what Adam was saying, and I actually agree with you, Adam. I think that plans and employers have more responsibility than to just share a price with people, because what I've been researching and what I'm seeing and what I'll be writing about in this article has to do with the fact that when you just tell somebody what something costs, right, but they have no skin in the game whatsoever, more often than not, they're drawn to the more expensive option because they think it must be better quality.
Bingo.
And if someone else is paying for it, why wouldn't I go for the better option? And even in situations where there is some skin in the game and they do pay for it, people still don't make the rational decision and are willing to pay more for what they perceive as quality. So the two things that I think are missing besides just transparency and skin in the game are, one, information regarding quality, the fact that you're not getting more for the money, and two, to your point, Adam, to get over that mental hurdle that more money equals better quality, throw an incentive in there as well.
Right. So I have a quick story. So I have a buddy of mine, Ted, who just switched health plans for his family. Even though I told him not to, Ted thought he was, Ted's a smart guy.
Ted, don't listen.
He's a short guy, but he's a smart guy. He doesn't listen much. I try my best to get this guy to change some things. So Ted calls me up yesterday and says, my wife went to her doctor, and they said that her doctor is not part of this new plan. So he's been listening to me talk. We get together once a month, and he goes, well, then what's the cash price? And the woman at the office literally told Ted, oh, no, we can't do that. It's illegal. It's illegal for them to accept money from him directly. So I told him to call back and go, listen, that's a bunch of crap. They have to have a price. So the lady finally says, okay, it's $230. And he goes, well, what's the self-pay discount? There must be a discount. She goes, no, that's the rate. So I then looked at our data and found out the average office visit like that, just a normal outpatient office visit, roughly has about a 50% discount. The $230 was pretty much in line what you see around here. So I told him to call up and say, hey, all the carriers that you guys do work with get about a 50% discount. I'll give you $130 cash. They hung up on him. This was yesterday. They hung up on him. But here's the funny thing, guys. I just think we're talking about the wrong thing today. And here's why. Go on LinkedIn. Look at all the articles that our industry talks about. Look at all the conferences. Everyone's talking about reference-based pricing, lower the cost of facility claims, lower the cost of physician claims. But yet, you have these amazing plans, amazing reference-based pricing plans that are saving 50, 60% compared to what the networks are doing. Yet they still have a PBM. Yet they still have their pharmacy costs. Brady, I'm going to put a gun to your head here. What is pharmacy spend going to be as a percentage of overall healthcare spend in 2020?
More, for sure.
Right. But of a plan's overall claim spend, what do you think it's going to be, roughly?
On average, I'd say at least a third.
50%. So everyone is talking about what we could do about this 50% on the facility side. There is some talk, and I know, Brady, you were going to talk about it a little later on about, drug pricing. But that, to me, is almost like, in our industry, people don't want to talk about pharmacy options or opportunities on what you can do because they actually don't even understand what a PBM is, what's in the actual contract. They will look at a facility and fight every day to push back on the hospital, get that charge to be lower the payment, get a direct contract. But when it comes to even a generic drug, take it as it is, which I think is rather interesting. We really, as an industry, haven't done much on 50% of the overall medical spend compared to what we could be doing. I want your thoughts on that.
Yeah, well, Adam, it's an interesting point you make, and I think maybe there is an element of ignorance, and I think maybe there's an element of fear. But also, if you think about it this way, right? I mentioned before going online and you look up the price of an appendectomy. You drill down a little bit more, it's easy to conceptualize, hey, if I go to hospital A, an appendectomy is $8,000. If I go to hospital B, an appendectomy is $5,000. I save money by going to hospital B. Now, how do I get people to go to hospital B? It's just this very simple line of logic. What you're talking about is, Sanzafram costs $10,000 a unit. And, does it cost more or less at Walgreens versus CVS? I don't know.
But that's one thing. It's whether or not the person even needs, what's this drug called? Sanzafram?
Sanzafram. I don't know. I just came up with this.
Does the patient even need Sanzafram?
Right. So it's such a more, complicated discussion because with the appendectomy, you know what you need, and it's just price comparing.
I agree that it's more complicated, but wouldn't you agree that we're at a point now in our industry where it's time to start talking and doing stuff? It's more complicated. We're experts. We should be getting involved in more complicated stuff. I just think that our entire industry is so focused on only half the problem that the other half the problem is just ignored because, as you said, Ron, it's complicated.
Well, I think so. One of the oldest, we'll say, cost containment measures that you see in a benefit plan is this idea of medical necessity, right? Where by the time a person is getting an appendectomy and you're comparing prices at different hospitals, it's assumed they need the surgery. It's assumed it's medically necessary. I think the problem is that with pharmaceuticals and drugs, before you start comparing prices, you have to ask the question, is it medically necessary? Now, I don't mean that they need the medication, but is it the lowest cost yet equally effective option?
But Ron, you mentioned is it necessary? Do you realize who is doing the prior authorizations to find out whether or not that drug is necessary?
I'm going to say it's the one who also gets a piece of the rebate.
It's the PBM themselves. They make more money authorizing bigger, more expensive drugs. So imagine if we did that on the hospital setting. It would never even happen. That would never even be possible. Yet because it's complicated, 50%. Again, think about it, guys. You have plans out there who literally got rid of their entire network. People's lives are changed. My buddy Ted is an example. We can't go to this doctor anymore. This doctor won't accept us, or this hospital won't allow us to come in and have a surgery because we are not a network plan. We're a reference-based pricing plan. All this put in place. Yet, how they pay for their drugs is still no different than it was a year ago, or 2 years ago, or 5 years ago. It's the one area that I feel there is so much opportunity that FIA and others in our industry could finally jump in on, put our teeth into it to see, is it really that complicated? Or is it really a focus on getting patients to really change their behavior and actually inquire to their doctor, are there better other alternatives available to me other than, what's that drug called, Ron?
Sanzafram.
Sanzafram.
Yeah.
What is that used for, Ron?
I have no idea. It's imaginary.
You've been quiet, Brady. I mean, you've been
it.
between Ron and I. The spit's flying both ways.
I agree everything you guys have said, but I think we're missing part of the picture, or at least half the picture, which is unlike wherever you get your appendectomy, what's going on here is you have manufacturers who are, in many cases, monopolies. They set the price. So if you need your EpiPen, you can't get your EpiPen anywhere else other than the manufacturer of the EpiPen, because in most cases, there's no generic available. So for these specialty drugs, which are the ones that are really driving the costs up, there's no other option. You can't go to Arkansas and get it cheaper. So I think we have to address that problem, certainly alongside this problem of whether the patient actually needs the drug. And one of the things I like recently in Congress is that they've been having these hearings, both recently with the drug manufacturers and now with the PBMs, and they've picked a new poster child for which drug they're going to focus on as having had its prices explode. It was last year the EpiPen and PharmaBro. Now it's insulin. And recently at a hearing, I took some notes on this, but unbelievably, the cost is still going up of insulin. It's now $450 a month for people, which is more than quadrupled. So there's all these horror stories coming out of people who are skimping on, they're rationing their insulin. There was one case of a girl who was, I think, 22. She just got phased off this juvenile assistance program for her insulin. As a result, she couldn't afford it. She was skimping on her insulin, and she actually ended up dying of diabetic ketoacidosis.
Right. What's amazing to me is we're in a country right now where people are dying because they're skimping on the insulin. Yet if you are a meth addict, the cities and towns and state will give you free needles in order to inject yourself with illegal drugs. So as long as you're doing an illegal drug, it's free. If you're actually taking a drug that you need to live, that's legal and approved by the government, yeah, we're not going to help you there. I think it's pretty interesting.
A drug that's been around since 1923 or give or take a few years there. And
since I've been born, basically.
Right, and according to the article I was reading on this, the version of insulin hasn't changed since like 1995. So you're literally buying the same vial. And when I was watching this hearing, it was interesting to hear how they defended themselves, the four big manufacturers of insulin. They really had no good answer other than, we need more money for R&D. And they didn't really have a good answer.
Folks, that's all the time we have for today. As you can tell, I mean, if you allow us to start talking, we could just go on forever. But anyways, on behalf of Pat Santos, our esteemed producer and future guest on the Face of FIA, Ron E. Peck, Brady Bizzaro, and myself, Adam Russo, thank you so much for empowering your plans with the FIA Group. Have a great day.
Thank you.